My name is Mona Das-Roberts, and I'm a pediatrician in primary care clinic at Boston Medical Center, and here to tell you about a quality improvement initiative that we carried out. Attention deficit hyperactivity disorder is the most common pediatric neurobehavioral disorder in the United States, with a prevalence of about 7 to 10% in school-aged children. Fortunately, ADHD is treatable most effectively with a combination of medication, behavioral therapy, and school-based supports. Unfortunately, many children with ADHD go undiagnosed and untreated, putting these children most at risk for problematic outcomes. At our Urban Safety Net Hospital, we examined whether universal behavioral screening was leading to appropriate evaluation and detection of ADHD. Let's dive further and take a look at our quality improvement initiative. Over 80% of children in our clinic were screened with a Pediatric Symptom Checklist for behavioral concerns at well-child visits. However, most children with clinically significant attention symptoms on the PSC were not receiving further evaluation for ADHD. We conducted a quality improvement initiative to operationalize a formal two-step screening process for ADHD, with the PSC followed by the Vanderbilt ADHD Diagnostic Rating Scale. Components of our QI initiative included provider and staff education about positive screens, adjusting our front desk and medical assistant workflows, automatic flagging of positive screens in the electronic medical record, or EMR, and facilitating next steps for evaluation via the EMR. The outcomes we assessed following a positive Pediatric Symptom Checklist, or PSC, attention score were: we looked at whether a pediatrician documented recognition of the positive PSC attention score, whether the pediatrician documented a plan for follow-up for this positive attention score, and whether the pediatrician distributed a diagnostic rating scale following a positive PSC attention score, and then lastly, whether the parent returned the diagnostic rating scale within our intervention period. Let's take a look at our methods. We used monthly run charts for each outcome over 10 months. We optimized improvements using the Plan, Do, Study, Act, or PDSA cycles, and we compared a full 10-month outcomes to our pre-intervention 10-month period. As you can see, here is an example of our run chart using our PDSA cycles, looking at each measure, whether the pediatrician made a plan, acknowledged the positive score, distributed the Vanderbilt Diagnostic Rating Scale, and whether it was documented and returned. You can see here the different time points and what was provided in those time points. We began with allowing for education of our providers and educating our resident pediatric providers. And then we looked at a 6-month period of individual provider feedback that was given to each pediatrician and some of our staff changes. Our results show by outcome that we did show an improvement in pediatrician recognition of a positive PSC attention score compared to our baseline or pre-intervention period. We did show improvement in distribution of the diagnostic rating scales compared to the pre-intervention period. However, no improvement was shown in the documentation of a plan for follow-up, and no improvement was shown in the return of diagnostic rating scales compared to the pre-intervention period. Many published quality improvement initiatives have focused on improving diagnostic assessment monitoring for ADHD, but to our knowledge, this is the first focused on implementing a 2-step process to improve screening for ADHD. We improved provider recognition of positive screens and distribution of diagnostic rating scales, but additional interventions are needed to improve completion of ADHD evaluations in primary care following a positive screen.